Hello, my name is Arnaud Lemmers. I'm heading the endoscopy unit of Erasmus Hospital in Brussels. It's my pleasure to present you our publication in endoscopy about the safety and efficacy of salvage ESD for Barrett esophageal neoplasia recurrence after radiofrequency ablation. First of all, I would like to thank all my co-workers, and especially Lauriane Mesureur, who is the first author of this paper. And I need to introduce that we had the opportunity to collect cases from 7 Belgian centers, 2 from France, 2 from the Netherlands, 1 in Switzerland, 1 in Italy, 1 in Sweden, 1 in UK, and 1 in Australia. So thanks to all of my co-authors to participate in this study. So the background is that, of course, in general, when facing superficial neoplasia in Barrett, we remove the lesion by endoscopic resection and we followed by ablating the residual Barrett with, most of the time, radiofrequency ablation nowadays. But we have very few cases of recurrences. This is about 1 person per year, and it is 2 to 7% at 4 to 8 years in studies. So how to treat those recurrences? We do not have any data. We know that we can find a severe fibrosis after radiofrequency ablation, and we do not know about the performance of ESD in this setting. This is a case illustrating a patient who had previous EMR for mucosal adenocarcinoma and 2 further sessions of radiofrequency ablation. He was a poor responder, as demonstrated on the left picture, with bulging lesion, biopsies positive for adenocarcinoma. And after discussion in MDT, we proposed complete Barrett removal using salvage ESD. You can observe on the right picture the severe fibrosis from the muscular propria, underlined by the blue arrow, and the fibrosis are the vertical fibers from this muscular propria to the deep submucosa. But it was possible to remove the full Barrett circumferentially without any troubles. And of course, the patient received preventive measure against stricture. The pathological analysis revealed a mucosal adenocarcinoma, and the patient had no more recurrence and no residual Barrett. So, in all the participating centers, we identified 56 patients from registries of patients treated by ESD and by RFA. So it's infrequent. Altogether, the en-bloc resection rate was 89%, with neoplasia remission ratio up to 70%, with a median remission time of 13 months. It was very safe. We had only, as adverse event, 1 muscular tear treated endoscopically and 7 stricture treated by balloon dilation. So this procedure was safe in the involved centers. If we look to the data on the risk stratification after salvage ESD, we had curative ESD in 33 cases with an end of follow-up remission rate of 97%. In some of the patients, we used other technique, resuming RFA or APC to ablate residual Barrett. In the non-curative salvage ESD, 22 cases, local risk was present in 11 with a good outcome, 72% of remission at the end of follow-up, and high risk in 11 with only 54% of remission at the end of follow-up. So altogether, we obtained 82% of patients in remission at the end of the follow-up, meaning that we had to resume other therapies in some of the cases after this salvage ESD. So the next step, of course, are to better define the severity of the fibrosis to predict the technical challenge before attempting salvage ESD after radiofrequency ablation. And also, it might be interesting to have comparative trial between EMR and ESD in this setting for the treatment of neoplasia recurrence after radiofrequency ablation. So to conclude, this is a multicenter retrospective study confirming that in expert hands, ESD is effective and safe for treating recurrence of neoplasia after radiofrequency ablation and might therefore be proposed in selected cases in expert centers. We need to stratify the oncologic risk after this resection, and we know that low risk and local risk resection allow excellent outcome when pursuing further endoscopic treatment and follow-up in those patients. Thank you for your attention.